and welcome back to Sullivan's Unheard Voices. I'm back with Dr. Jami. Thank you so much for coming back again today and having this conversation about autism diagnosis. And when did you start providing that as a service? Remind people, because you mentioned it before, but remind people.
I'm like, I did mention it before. Did I mention it before? I started doing assessments with the Adult Autism Assessment and Services company in January of 2023. So almost, we're coming up like a month from now, I'll be at my 2-year mark with them. Yeah, and I can't remember if I'm like, I should have listened to our other podcast before it came on again, because I can't remember if I said like the specifics on like the journey to how I got involved with them, which like partially stemmed from my own
a little bit, but go ahead and go ahead and remind people.
Yeah, so part of that stemmed from my own frustration around my own diagnostic journey, and hitting dead ends with the assessors where I was trying to get assessed, and like having that one that had basically said, you're too successful to be autistic. And I was like, this is still interfering with my life right here. So I'm telling you, and then also like trying to find a non-ableist resource to refer my patients to. And so, and then discovering like, oh wait, I can also be one of the ableist neuroaffirming resources to my patients as well. So that was really cool, of like realizing that yes, it was indeed within our scope, because other fellow naturopathic physicians were already in the field doing it. And so it was like, yes, I get to join this crowd.
And the demand is still high. Like we still need people to do assessments, like more than anything else, I think.
Yeah. Well, and then honestly, so what, I don't think I included this part before, but what ended up happening, so I still work for that company, and the majority of the assessments I provide through them. So I'm also licensed, in addition to being licensed in Oregon, I'm licensed in Washington State and Vermont. And so serve those communities. And if I did say this last time, sorry for repeating myself.
It's all good.
I'm like, that's my classic line from life is sorry for repeating myself. But
story of our lives.
Right? So I serve like all three of those states with that company. And technically I serve all three of those states in my private practice as well. But was initially just doing assessments through Adult Autism Assessment and Services, up until, I'm trying to remember, it was at some point last year, or maybe early this year, where we were running into the issue because the assessments there, our practice there does not take insurance. And so it's an out-of-pocket cost to people. And so they do offer a financial like sponsorship program where people, at that time, there was like a 50% off tier. And then I think there's like a 2-step tier this year where there's a 25% level and like a sliding scale type thing. So that it was like, they expanded like what income limits, I think, in order to offer that other tier.
Okay.
And so, but even with that, the cost was still out of reach for a certain group of people who don't have an income, right? So it's like,
right.
50% off of zero, or 50, or not, what am I trying to say? I'm saying it backwards. Like, even if a assessment, so last year, I'm like trying to remember the prices, because like cost of services goes up on a yearly basis in healthcare, right? And so
Yep.
this year I'm like, what's 880 times 3? Because it's like we have a 3-session assessment process there, and it's 880 per session, and it's in installments. So it's not like this session, the amount of stuff that we discuss in this session is worth $880. It's we're the total cost is why
I
can't
get
I
it.
do that in math in my head? 2,400 plus another $240, which is 2,640, right? Okay, so I hope I did that math correctly. And right, so even 50% off of that, right, is still 1,320, right?
Yeah.
Which is still out of reach for folks.
For a lot of people.
Right, because
Yeah.
like, if you have zero, you're not going to be any more able to afford $1,300 than you are $2,600. I mean, yes, you may be able to access that money quicker and easier than you would, right? Like, but still, it's still like
$6,000 or $10,000,
right,
but
right.
yes.
But it's still like it's anyway. So we're still encountering that obstacle, and so still like the access was still restricted from like the most vulnerable among us, right? And so I was like, how do we bridge this gap? Because we're running into this issue where like these people are really seeking assessment, and it's not accessible. And so that's how I ended up shifting to offer it, because in my private practice I was already seeing Medicaid patients on OHP.
Okay.
And so I had a discussion with our practice owner at Adult Autism Assessment Services, and I said, I really want to like have a safety net for this group that has restricted access, and I don't want it to be, this is like the autistic sense of justice, I don't want it to be a conflict of interest and feel like I'm taking clients away from this practice.
I get that.
And she responded with, well, those are the clients we can't serve at this practice. So I'm so grateful that your practice has the capacity to meet their needs, and take their insurance and all of that. Like, thank you for like catching them, basically. Right. And I said, like, so in our, and I don't know, I'm like, is it okay if I go? I mean, I'm like, I think this is what our discussion was intended on going into, but so our assessment tools in that practice so we do use some of the standardized tools there, but then our practice owner, who's been in the field for like, I think like right around 30 years at this point, has adapted the language in from the assessment tools to be more neuroaffirming, but it's not yet in publication.
I love that.
Yeah, I love it. Oh my gosh, I love it. Like my favorite my favorite question from her assessment materials is in the part A, so it's the social interaction ones. It says, at a party, I would rather spend the evening with the host's cat or dog than interacting with the other people. And I'm like, oh my gosh, this is like so like quoting my life.
That's it. That's it. Oh, that's it. 100%. That's it. 100%.
Versus like, how like clinical the ones in those like in the published works are just like, I mean, like the ADHD example always comes to mind with like, the child acts as if driven by a motor. And I'm like, who talks like that aside from these like boardroom scientists, like calling things. And
your normal person that's coming through for the diagnosis they're going to have no idea. So having these kind of terms helps sort of like, so let me think about this for a second, because like the general question is more about what you do at a party and whether you go to parties, right?
Right. It's like, do you like social interaction with other people type thing, right? Like, so like the bullet point, let me see.
Instead of
Yeah, no, go ahead. Yeah, because I was going to see
Yeah,
if I could
please.
find the DSM
No,
bullet
because
point, but
yeah, while you're looking that up, you're right, because like I've heard so many people get frustrated at the traditional assessment piece when it comes to friends, because they ask questions. It's like, do you want friends? Yes. Well, then you
Mhm.
can't be autistic. Well, there's a difference between me wanting friends and me having the ability to have friends that don't abandon me after 2 weeks. There's a huge difference there.
Right. And how I interact with my friends might not look the
Yeah.
same as how neurotypical folks are interacting with theirs.
Mm-hmm. Yeah, I get accused of being a hyper communicator all the time.
Yeah. Yeah. Okay, where is in the picture form? Ooh. Of course, this is
Ah,
from Dr. Neff's Neurodivergent Insights page. Yeah, let me see. Criteria A. Yeah, like it was like under that one. Oh, yeah, maybe I just pull up the assessment tool. Because yeah, it was under the social criteria A for like social interactions. And I think that I'm sorry, I'm like trying to do it fast so it's not like like all this silence space. I can't handle the silence. Um
right.
where yeah, the little or no interest in peers section of part A.
Yes,
Yeah.
I hate that, because that just misses the mark about autism altogether.
Yeah. Yeah. So I
Because
love
like
how
I don't know
yeah.
if your experience, my experience is in terms of like universal truths, right? So more often than not, everybody that I run into or converse with who's autistic wants to have friends
Mhm, mhm.
and wants to have those peer groups. They just don't seem to be able to find them, which
Yeah.
is way different than not wanting to. And I think that's a very important distinction, because a lot of people are under the assumption, and this is part of like that media portrayal of autism,
Mhm.
that you don't want to be around people. And I'm like, no, I crave people. I
Yeah,
just
and just
suck at
because
it.
I'd rather hang out with a cat or dog, the host cat or dog at the party, doesn't mean I want friends, but that is how, yeah, that's how I look. I look as if I have little or no interest in peers, right? If we're looking at it
Yeah.
through a pathology lens, I look because yes, there are less demands put on upon me by the cat about me expressing how I am interested in the cat than some people, right? Like if I'm like
100%.
very, I don't know, if I'm making the conversation that I'm having with a peer or with a friend all about my special interest, they may, right, if they're more neurotypical, they may perceive that as me not caring about anything about them because all I want to do is talk about myself and what I like. And it's like, no,
Yeah.
it's like your kid going, look what I made at school. Like I felt is how I feel, or like, or the cat bringing back the mouse. Look, I hunted for you.
And in terms of communication too, what I have found is that that's your when I'm focused on the subject that I'm hyper focused on, it's the most readily available for conversation. So if you want to talk about something that isn't tied to my significant interest, it just takes me longer to process and be a part of that conversation. And so I have found over the years that's helped me a lot in conversing with people who are neurotypical. Um, and I'd love to have a conversation about that term at some point. But when you have that conversation with neurotypical, I have to remind myself to avoid my hyper focused subjects altogether, and that has been so beneficial, because like I want to talk
I know
about
it seems
everything that
sad
I
though.
see and hear and all this stuff, and I have some. But what's that?
I said it seems sad. Like, oh, I have to avoid this thing that I like in order to like interact with them the way they want me to.
That is exactly right.
Yeah.
And I also know that they're not going to make the concerted effort back. So, like, if I knew that the person I was talking to would give me like that two-way street, even if you feign
Mm-hmm.
interest in
Mm-hmm.
my subjects, right? That would be awesome. But it's been my experience that most people who aren't also on the spectrum don't have any time for those conversations. They just like, oh, it's not something I'm interested in. I don't want to hear about it. I'm
Yeah.
not interested. Can we talk about something else?
Yeah. Yeah. You're supposed to
Every
do the
time I talk to
opposite.
somebody else,
Yeah. Sorry. I didn't mean to cut you off. Sorry.
no, you're good. It's autism communication at its finest.
I feel like we should have like this tally board of how many times I say sorry unnecessarily, right? Like, and here is number 4.
I do it at least. I do it at least 20 times a day. Sorry, always, because I'm always.
Yeah. And then the apology for saying sorry. Like, that's the best one, right? The meta, like.
Yeah, story of my life.
Sometimes I will.
I have a good friend.
Yeah, go ahead.
No, you first.
Oh, yeah. I feel like there's also like kind of a slight lag in the audio too. So I think that like is contributing to like oh shoot, I jumped in before the talking was actually done. But yeah, so
oh yeah, okay.
Right, yeah, so I was gonna say, you know how like in therapy, right, your therapist will be like, okay, so we're gonna work on you not apologizing unnecessarily for things and recognizing when it's actually needed versus the people pleasing thing that you've been doing. And so they're like, look for other ways to phrase it, like instead of saying, sorry, I'm late, thank you so much for your patience waiting for me to get here. I really appreciate you waiting a little bit longer until I arrived. You know, something to that extent.
Oh, interesting.
Yeah, so that it's not like, I'm sorry for these things that I actually couldn't handle because there was all this traffic that I didn't anticipate, right? In that example. Yeah, it looks like you have a question.
I appreciate that. No, I'm processing.
Yeah.
Because that has just opened so many doors to me. Because I fall victim to that all the time, right?
Mm-hmm.
And I guess it never occurred to me to take a step back and just like think about why I apologize so much.
Yeah. Well, I mean, I know a lot of mine is sourced from like being gaslit in various situations and, you know, blamed out of like when it wasn't actually my fault. And so, right, like, it's like, I mean, and that's most people's story, right? Oh, here, yep, that came directly from the trauma. But yeah, I was gonna say that like when I apologize for apologizing, I try to do it with that. I'll say, oh, I noticed that I said sorry a lot. Thank you for being so accepting of my tendency to do that. Instead of saying sorry for saying sorry. Yeah. Anyway, so like, I get a kick out
and
of it.
I was going to say I have I was going to say I have a really good friend who does that a lot, and she always blames it on her Catholic upbringing.
Mm-hmm.
She's like, I was raised Catholic, and I was born to apologize and suffer.
I've gotten a similar like remarks regarding my apologizing, which was, I'm like trying to remember how it was worded, but something to the effect of, you'd make a very good Catholic. Ah! And I'm like, oh, thanks. Did you ever hear that Robin Williams comment about, so apparently he was Episcopalian, so which is part of the Anglican Church. I don't know how much background, right? Mm-hmm. I'm like, oh, here we go, special interest or former special interest of like, yeah, I'm info dumping on, but yeah. So the Episcopal Church is like the American aspect of the Church of England, Anglican Church, that was like broke off from the Catholic Church so that Henry VIII could get divorced, basically, or like that's the urban legend around it, which I think has an element of truth. I think, if you went into the politics of it, it's probably more convoluted than that even. But anyway, so Robin Williams said, so apparently he was Episcopalian or something. And like in some of his stand-up routines, he'd say, yeah, I'm Episcopal, or I was Episcopal, and it's like Catholic. It's like Diet Catholic or Catholic Light. Same service, half the guilt. And I was like, this is yeah.
Oh, that's a good one.
Yeah, I got a kick out of
Oh,
that.
I missed that guy.
I know. It's been 10 years. It was 2014.
I know.
Gosh, yeah.
I can't. Where's the time gone? So anyway, circling back then to
Yeah, I know,
the actual
like, should I get back on
assessment
track?
piece. Yep, we'll get. I got you. Don't worry. So so you have this tiered pricing, and you have the ability to help people who with certain kinds of insurance locally. What's the first step in the process?
Can I clarify around that? So the
yes, please.
Adult autism assessment and services practice that's where I'm an employee of theirs. And so I work part-time hours with them around my private practice schedule. And so their practice, that one is the one that has that 2-tier system. It's all out of pocket. People can get like what's called a super bill, and they can submit that with the codes to their insurance for reimbursement. But the practice itself doesn't do any insurance billing. So it's all a cash pay. I hate using the word cash pay because it's like you can pay by credit card. It's all a self-pay arrangement.
Right.
And there is that financial assistance aspect to it where there's the where they're having that 25% off or the 50% off depending on the income level. But that I was trying to catch the people that were falling through the cracks that were Medicaid patients. And so I had that conversation with the practice owner saying, like, can I help address this need in my private practice? I won't use, I guess this is where we're starting to talk about the assessment tools. I won't use your proprietary assessment tools because those haven't been published yet. And I want, right, like, I don't want to just like, here, I'm going to use these.
Yeah.
Right. I'm like, when they get published, I am happy to pay for those if I am wanting to use them. Because I would rather use those in my private practice because they're more neuroaffirming. And I hate it's a strong word. Okay. Some of the language in the standardized materials is quite ableist and mostly pathologizing, right? Because that's what it's designed to do.
Yeah.
Because it's like looking at it from that medical scope, right?
The medical model.
Yeah. That it just, right. So I like the fact that adaptation that she's made to make it a better experience for people getting assessed and feeling more aligned with their actual lived experiences instead of being told, here's all the things that are wrong with you type thing, right? Like where it comes across as this like criticism. So all that to say is I also now, did I drop my connection? Am I back?
No,
okay.
You're good.
Sorry. It did like a little circle of death thing. So I was like, no, am I here? So I started doing, like I said, I think it was earlier this year at the end of last year, where I started offering assessments within my private practice to the Medicaid patients that were looking into that, that weren't being able to be served at the other practice. So the ones that, so I wasn't stealing patients away from the other practice. And so in my private practice, in the other practice, we use her proprietary tools plus the SRS2 social responsiveness scale second edition or
Okay.
version 2 or however the language you use for that, which again has that more ableist language. Like one of the questions is even, I have good personal hygiene, and you're supposed to say how true that is, and I'm like, like, I'm like, first of all, is that like, are you lumping that in under how autism interferes with my daily function? Like why that question got
I
included?
don't know why that's related.
That's the only one that I can think of how it ties in, is like where your symptoms are interfering with your functionality. So
Okay.
like I'm like, I think that ties into that. So but whenever I'm delivering that tool, I do, like, prior to discussing those questions and delivering those questions to the person that I'm assessing, I say, I want to bring awareness, give you a heads up around this language. And the other thing about that tool too, and like I want my criticism mostly to land neutral as far as like
Yeah,
just
I get that.
going, hey, here's what I think are some limitations here. But obviously, like some of them, I'm like, this is rude and not, and it feels slightly discriminatory, right? Like, but yeah, and so like some of the language in some of those questions, just like there's several of them that ask for perspective taking of like other people think, and then I'll have whatever they're asking about of the other person's perspective. And it's like, I feel like even like the ability to understand that those questions should be like indicative of whether you're autistic or not, because it's like you're being asked to see something, to have the awareness of something from somebody else's point of view without them telling you. Right? So like,
And I'm processing that. So I did not go through a formal assessment process. So right now I'm thinking in my head how I would answer that question. I don't know how I would answer that question.
yeah, so I'll see if I can pull an
Wow.
example up from that one.
Because like I spend so much time trying to ascertain or figure out what somebody else's experience has been through, right? Because
Right.
I have a lot of empathy. But I've given up trying to figure out like people in general because it's so confusing.
Uh-huh.
But I don't know if that's different, right? Because like I do perspective taking, but I also know and I recognize my limitations there.
Mm-hmm.
So I was like, how do you answer that
And
question?
you've
That's
had
such
to
an
really
odd.
work at it, right? It doesn't just come, it's
Yeah. Oh yeah.
yeah. Whereas apparently for neurotypicals, they're like, oh yeah, like, because I've had that where where I've been like, how could you tell, right? Aside from like
Yeah.
obvious, like, oh, this person's crying or whatever, right? I'm like, how did you know what was going on for them? And they're like, oh, you could just tell. And I'm like, how? And it'd be like these
Yeah.
subtle indicators, and I'm like, wow, right? And then I'm mostly reflecting on like what childhood was like and teens and stuff like that, because like now, yes, I have those skills, but I studied psychology and
Yeah.
I studied medicine, so I trained to learn how to do that, right? And so, but it should not
Yeah.
require a doctorate in order to be able to do that.
That's interesting.
To
Like
read social cues.
that yeah, cuz like I like if it's overt and over the top I can tell. Like if
Mm-hmm.
somebody's crying, I can tell that they're crying. I can't tell you if it's crying because they broke a leg or crying because they're like having an emotion, like all of that stuff. I have no idea.
Right. If you didn't see all the
And
context leading up to it. Yeah.
yeah. And like, I didn't even know people communicated with their eyes until I was 40 years old. Like, I had no idea. Like, I had no idea eye rolling was a thing. And so I had all of these meetings that I would have, and I thought that they would go well, and then people would report back that it didn't go well, and that people were feeling this or doing that. I'm like, how did I miss all of those subtle cues? Well, because I'm autistic.
Try to find one of the question examples of other people think. Oh, yeah. People think, okay, so yeah, here's one of the like repetitive behaviors, restricted interests example. So it's people think I am interested in too few topics, or that I get too carried away with those topics. And it's like, again, how do I know unless they've expressed it?
Right. I'm going through the Rolodex of my life now that I listen to that question, and I have no clue. I've never had that conversation with anybody.
Right. And early on, right, like we might get the feedback of like, oh my gosh, will you shut up about talking about this, right? Or
Yeah.
right, but you know, maybe some people are more polite about how they're trying to like reel you in, that they're like, oh, that's nice, and then they try to start talking about what they want to change the subject to, and then like you continue talking about your special interest, and they're like, oh, that's nice, you know, and right. So like I had to learn that the, oh, that's nice, change the subject meant that people thought that how was it phrased again? How did I just read that? I scrolled away from it. Right. That other people think I'm interested in too few topics, or I get carried away, or
Too few topics.
Yeah. Right. But I didn't innately know that until it got explained to me. Right. So that's my joke about the questions themselves, is that like you don't know what they think. And so like sometimes people they're like, I don't know what the answer to this question is. And I'm like, right.
Yeah.
I'm like, I feel like that in and of itself is like an indicator, because it comes difficult to us to be able to go, what do other people think when I do this? Right. Again, unless they've explicitly said what they think. So, yeah. So that, I mean, so that's that.
Yeah.
Tool.
My whole and my whole existence has been not knowing what other people think of me. Right. So
Right.
like I always assume the worst too. And so I have a habit of saying, like, thinking like, I don't understand why people would like me, or I don't understand why people would like to hang out with me. And then I finally came to the realization through therapy, like, I'm kind of a cool guy. Like I'm nice, I'm sincere, and I'm non-judgmental. And now I get it. But if I didn't go to therapy, I would have still had that zero self-confidence. Like none, zero.
Yeah. Well, I'm like, I have that, and then I'm extra annoying because I will ask, like, I will incessantly ask, oh, well, what, right? So if somebody is like, gets upset with me or gets annoyed with me, and I'm like, wait, why are you annoyed? Because of this. Wait, why is that annoying? Because of this. That doesn't make sense to me. Can you explain that to me? No, your questions are annoying, right? Like, so I'm like, I'm just annoying, right? Like, yeah.
I wish I had the power and the permission for myself to ask those questions. I am too afraid of the answers, so I would never ask.
I understand why you're afraid. I guess I don't know if it's like the blessing and the curse of like the ADHD impulsivity part that I have, because like I have that part where I'm like, if I ask this, somebody could get annoyed about me asking it, but like that doesn't happen quick enough for like me to filter it half the time. And I'm already asked the question and risk somebody getting further annoyed with me. And then I'm like, oh crap, you know, but yeah. I mean, you know, it is what it is. It's navigating the world as a neurodivergent.
Yeah, it's definitely interesting. So let's circle back to the
Yeah,
diagnostic piece again.
yeah.
So you said that the one you use outside of that proprietary one is called the what?
That's the SRS2, which stands for Social Responsiveness Scale, second edition. And so it's the, what is it? Western Psychological Services that publishes
Okay.
that one. Um, they also do
Is
that,
that
the
the
app that
standard that most places use?
I don't know. I know a lot of places use it. So like in their, that distributors, that companies, not the assessment company, but the one where we purchased this tool through, they have a lot of those. They're the ones that sell the ADOS, that's the main one
Okay.
that's used in childhood assessment. And there is an adult uh chapter. I'm like, what for terminology do you want to use?
Okay.
Module for the ADOS. I have not heard good feedback from people who have been assessed as adults with the ADOS, that it felt kind of condescending, like as if they were being assessed with a tool designed for children. Um, and
Okay.
I see where it could have utility with people like level 3, like higher support needs, that may also have a co-occurring um like intellectual disability, right? And where like the tools that they're engaging with don't require this like heightened aspect of like intellectual capacity. I don't know if is that making sense how
It does. It makes
yeah.
sense.
I'm like, or am I using too technical of terms? I just like I do that. So I'm like, sorry.
Yeah.
Sorry,
You're good.
listeners. Yeah, that that SRS tool is through them. I yeah, so in with the adult autism assessment and services, we use the proprietary modules that Dr. Wendy Marsh authored, um, and hopefully gets published down the line, because I think that would be a real asset to the community and to clinicians in general. And then the additional tool we use in that practice is this SRS2. And then my private practice, because I don't have access to the proprietary uh, assessment tools, I do still use that SRS2 because that is available for purchase directly to clinicians. And so I
Okay.
purchase that through my practice. And then also through the Western Psychological Services. I keep like wondering if I'm saying their name right. Am I saying
No, you're
Western?
good. I would let you know.
Yeah. That so there's this other one called the MIGDAS, which is Montenegro, and I hope I'm pronouncing it right. Montenegro Interview Guidelines for Diagnosing the Autism Spectrum. That is also
Okay.
-2, second edition. So Dr. Marilyn Montenegro, I think she's also a psychologist. So she authored that, and it looks like she is a co-author. Sherry Stigall, or Stigall. Again, I'm not sure if I'm pronouncing things right. So that one was it was an attempt to be a more neuroaffirming diagnostic tool, and it's
Okay.
done in an interview style, and it is aiming to be more interests based as far as how the interview questions are designed. And so it's engaging the potentially autistic person on in the way that we're more apt to communicate and we're more apt to engage around things. And so it's still gaining information about the same areas of like, right, like the social interaction and repetitive interests, restricted behaviors, sensory needs, etc. But it's doing so in a conversational way, but also not making the conversation oriented toward being mainly a social interaction, right? So that it's not
Okay.
basically so that it's not
Yeah.
activating our sensory concerns, right? That there may be at times where it is, right? And then that's even in like the checklist review at the end where we're compiling all the data and where we might note, oh yes, when discussion tended towards this, these subject areas, the person being assessed had was a little bit more activated. I can't, again, they had specific language around it, I guess. And again, I guess I could give an example because I have the thing right here, where so it's like displays limited, so under the heading of facial expressions and overall quality of emotional responses, so the category that is more aligned with autistic presentation describes it as displays limited interest in and limited sharing and shared enjoyment of the evaluator's comments or actions. Right. So again, right, I feel like I keep using these examples of when we talk about our special interests thing, versus a neurotypical, that category on the table says responds with interest and shared enjoyment to comments made by the evaluator. And yeah, it looks like you're processing, have a thought. So go ahead.
That's a puzzling one. Cause let's break that down for a second. Cause
Mhm.
it's so interesting. Cause I have found more people that I know who are autistic have a profound desire to learn from people and appreciate learning new things. And that, so I'm like, how is that a judge? You know what I mean? I guess that's where I'm struggling.
Well, and it depends on, I think, right? So this is a perspective I have on these tools is I think they also make an assumption that the assessor, the evaluator, is neurotypical.
Ah.
So I feel like that is a thing, right? Because I might, because I'm also autistic myself, right? I'm going to subconsciously take things into account for the person I am assessing in order to work with their sensory need, right? To be affirming and be accommodating, right? Which is part of our conversation last time we met, right? And so
Yep.
I feel like it ends up being a confounding factor in my evaluation of would this person have an even would they be more symptomatic, so to speak, if I wasn't a member of the community and wasn't approaching them in a neuroaffirming way. But also I
get what you're saying.
I feel like it also helps catch the people that would fall through the cracks when it is delivered in that way. Right? Because I feel like I have a better, right? Which is not to say oh, I'm so much better at assessing, but I feel like I have a better read on masking and, on how we present, because I ironically know how rigid the criteria is written, and how without, if a clinician doesn't have that perspective, they don't even realize to consider that like you were saying earlier of we want friends. There's this presumption that we don't want friends because these behaviors get perceived as if we want to be left alone, when in reality, it's just that in order to, for example, attend to our sensory needs, we might need to take a break and hang out with the host cat or dog and take a little break from the party. But it doesn't mean we don't want to be there. It doesn't mean, or like, black and white don't want to be there. And it
Yeah.
doesn't mean we don't like the friends who are throwing the party. It just means that we can't show up in a neurotypical way for the party. But
And now
it ends up getting looked at as, oh, we don't desire friends.
And now that you say that, right? Like I can think about like instances in my own life where I've been in situations where I would love to go to the after party with the band and hang out with the band and all that stuff in the background. But by the time the concert is over, I'm so sensory drained that I can't. And so I have missed so many opportunities for increased connectivity, increased connection, increased relationships. But my sensory limits are such that I just can't.
Yeah. It's like, can we have the after party like 3 days later?
Right? Or just take a break for 2 hours and then come together, right? Yeah. That would be so awesome if that were to happen. So another thing that has piqued my interest in terms of the diagnostic piece is that when I talk to people that have gone through this process in various places, some places it's like 3 to 6 hours. Some places it's like 18 hours. I've even heard like a couple of them where they do like 24 hours of diagnostics. And I'm curious as like why the discrepancy in how much time it takes. I'm curious if you have any insight there.
Yeah. So, I mean, I think, okay. So like one aspect is like not everybody does the same battery of assessment tools, because there isn't like you need to use 4 different tools to gather this data, right? Like it's mostly like use whatever tools that you need to gather this data. That's I feel like I worded that weird. Use whatever tools you need to. If you have to MacGyver it.
No. You didn't word it. You didn't word it differently. I was surprised that there isn't a standard.
Yeah. I mean, so like, I think there attempts to be one, right? Where it's like, yeah, everybody should use the ADOS, or they should use the ADIR, which that one, what's the acronym? Again, that Western Psychological tells that one too. ADIR. That one is, if this will load, Autism Diagnostic Interview Revised.
Interesting.
And anyway, so I mean, there are several different tools, right? Like obviously, I've mentioned a handful of them. And I mean, the main thing that an assessment needs to include is it needs to thoroughly assess each of the categories that are part of the diagnostic criteria in the DSM. Right. So
can we go through those categories?
Yeah. Ooh, can I do like a screen share thing? Because I like that. I don't know if I can do that.
I don't know.
Or maybe I'll send you a link and maybe you can do a screen share. I don't know.
You can actually.
Okay.
On the bottom, there should be a share part.
Okay. First, I have to figure out how to share. No. Yeah, because I was trying to see.
Screen sharing permission.
Is this going to all be on the same? So I'll just end up scrolling down, maybe. Yes. Okay. Does this have a? Yes. Okay. So I'm on Dr. Megan Anna Neff's website because she also autistic ADHD psychologist. She actually is in Portland. She co-hosts the Divergent Conversations podcast with Patrick Casale, which is like one of the top trending Sorry, I'm plugging it on your podcast. Sorry.
I don't care.
Maybe they'll refer or
Yeah,
recommend in the
that would be awesome.
feed. And but yeah, so like so a lot of the materials that she produces is, again, very neuroaffirming.
Yeah.
And so that's why I like her referencing her website. Okay, so I was gonna see if I could like full screen this or something. Okay, and then my share thing, share screen. Okay. Okay, what do I need? I need to grant you permission to, or grant this app. Oh, I can't do it when we're in the middle of recording.
What?
Wait, it says Riverside Studio
It's
may
not Zoom.
not be able to record the contents of your screen until it is quit. You can choose quit now, but if I quit the application, won't it stop the recording?
Yeah, probably.
Okay, so I'm gonna.
So we'll just go without it.
Okay, so I'll just
Yep.
read it instead of having the accompanying visual, which would be more
That's
accessibility friendly. Okay.
It's transcript, so you'll have the transcript, so it's good.
Okay. All right. So yeah. So the criteria A. So for criteria A for the autism diagnosis in the DSM, there are 3 subcategories for it. All 3 subcategories must be met in order for criteria A to be met. So if they only meet 2 of the subcategories, they're not meeting the criteria for an autism diagnosis. And then she includes a bunch of additional commentary around like how this impacts AFAB, right, assigned female at birth, right, and other minority, like people of color, the LGBTQ community, because like the criteria A, because it's a social part, right, that was based on how boys presented, right, and so it's like, whereas again, that's good, like that could be a whole other episode of discussion.
You're not lying. Oh. So what are the 3 criteria?
So criteria A, the first subcategory is called differences in social emotional reciprocity. And that talks about, so I'll just quote it from her description. Social emotional reciprocity largely refers to the ability to fluidly and flexibly engage in a back and forth conversation. And she says there are many reasons this is hard for us. For one, with casual conversation, it is hard to know what to expect, and there are many context cues to pay attention to. Another reason this can be hard for many of us is that we tend to have slower processing speed, particularly when our brains are taking in information from many different sources. Hint, this is precisely what we're asking our brains to do during a social conversation. Because during a social conversation, we need to focus on the content being discussed, consider our response to the speaker, attend to our body language and theirs, pay attention to the person's energy, focus on not being too distracted by the environment, and and more things than that, right? Like those are just like the first 5 things that like she's listing, right?
Yeah.
So like that is a lot of, it's very taxing on our like executive function.
100%.
Yeah. So so then she has a little, I mean, is this going to let me? Yeah. So examples include tendency towards having a flat affect or monotone voice, right? So the like kind of blank face, or talking, what's funny is when I'm like talking about monotone voice, I say it in a monotone voice. So even if I have more expressiveness in my vocal range, when I talk about monotone voice, like I say, a very monotone. It's like, I think that's part of my like brain doing the literal thing of like, I'm reading monotone, so read it as monotone. Um, anyway,
Yeah.
okay, so that is example. Another example is difficulty initiating conversation outside of your area of interest. Difficulty with small talk, and you might use
Oh yeah.
pre-scripted lines to and describe it as confusing and exhausting. And difficulties with back and forth conversation, particularly in the context of small talk. So that's criteria A, subcategory A1, right? So that's the first of three. So the second is differences in nonverbal communicative behaviors used for social interaction. And so that includes eye contact,
Okay.
moderating our tone of voice. So like, again, like tying into that, like it can be, but also be the volume of like, oh, I talk too loud or I talk too soft for the occasion, right?
Oh yeah. Okay. So
Kind of
like
like
for
we started
example,
off today, and you're like,
yeah.
loud.
And so for the example that comes to mind, I just lost it. I
Oh,
hate
sorry.
it when that happens. No, you're good.
Should I talk too loud
It
again?
was fairly no. uh, the piece about tone of voice. If I'm calling customer service, I tell them ahead of time that this is my tone of voice. I'm
Yeah,
not upset. I can't control it. Because everybody assumes when I'm focusing on my words that I'm upset or
yeah,
I'm frustrated,
yeah.
but I'm
Well,
really
yeah.
focusing on my words.
And then it can go the opposite direction too, right? We also have difficulty the opposite direction where we're listening to somebody else's tone of voice and we're like, are they upset? And they weren't, right? Or yeah, yeah.
Yeah. Oh, yeah. I totally didn't realize that my receptor for tone of voice was off until I was like 40 years old. I had all of these epiphanies right around age 40. Like, holy cow, why didn't I know this like
Yeah.
40 years ago? But I digress.
And then the other aspect of this criteria is like the integration of gestures with communication as well. And so, right, because that falls under the nonverbal communicative skills. So here she says, she gives examples of difficulty intuitively understanding nonverbal social cues from body language and gestures, and tendency to minimally communicate through facial expressions and gestures, and a dislike of eye contact. Again, are examples, not to say like everybody has to hate eye
Yeah.
contact, but like verbal
Yeah.
and nonverbal presentation is not aligned, right? So somebody might be, I feel like this is where this overlaps with like somebody having a trauma history too, right? Where like they might be smiling, talking about something really tough. But, or yeah, that flat face of like, you don't seem excited about this. Yes, I'm excited about this. You can't tell I'm excited about this.
Right.
No, you look like you're pissed off, right? And then the moderating tone and or volume of voice.
Okay.
Yeah. So that's subcategory 2, and then the subcategory 3 is differences in developing, maintaining, and understanding relationships. And the examples on that one: difficulty initiating and developing allistic friends. So cross neurotype. Difficulty maintaining friendships, difficulty with shared imaginative play or shared group projects that require high reciprocal input and output, and difficulty with context shifting. Yeah, I feel like that one, right? Like where it's
You mean like a shift in focus?
I feel like that. Does she give an example in that one? Yes. Ooh. Context shifting refers to the ability to shift language, tone, body, and general way of being from one context to the other, such as how to act at school versus the grocery store versus a party, right? So, So like
No.
how, again, to reference, right, without sharing too much out of Dr. Marsh's proprietary tools, one of the ways that, well, actually, this was in an earlier edition that's no longer in the current one, so maybe it's okay I include it. But had included like a person might act the same and dress the same whether they were going to a bowling alley or Buckingham Palace was the example that had been used at that time of like, so somebody might be
I
too
relate to that so
formal,
much.
right? Like might be too formal for an informal setting or too casual for a formal setting, or, you know, like instead of being able to go, oh, wait, I'm going to hang out in the bowling alley. I should, you know, I shouldn't wear this, right? Like
Yeah.
I personally am like, I just want to wear what's comfortable. I think actually how that showed up for me was, why the heck do I have to wear a dress shirt to an interview? And especially if the interview wasn't even
Oh,
for something you would wear a dress shirt for. Right? That it was like, what? You have to look nice. Like you look like you care about it. And I'm like, but yeah, again, right? Like I'm like, why does this be the marker of this?
I remember when I got out of the military, the first job interview I had was for because I was a mechanic in the military. So my first job interview was on a job at Jiffy Lube.
Mm-hmm.
But I didn't know, so I wore dress pants and a dress shirt, and they didn't give me the job because I looked too nice.
Right.
Like,
Yeah. So that's the other side of, right? Yeah.
Like, you're not dirty enough to work here. I'll never forget that. Like, you're not dirty enough to work. What?
Yeah, they wouldn't have paid you what you were worth anyway, right?
Right. That's
probably
fair.
would have been way more skilled than what they'd actually have you do. Oh man. Anyway, sorry. It's like no filter.
But it was tough. It was finding jobs has always been tough for me.
Oh man. Yeah.
Like,
well,
always.
I mean, and usually, right? It's like you're actually end up being overqualified because you amass like all this technical knowledge about something, but it's like you don't look like how people look. Yeah. Like I have a whole soapbox.
I totally understand. You and me both. Because, like, I know so many things about so many things, right? Like, I can talk to you intelligently about transarterial bypass surgery in the brain. I can talk about things like medical related that I learned when I was working for a heart surgeon. And at the same time, like, I know about technology and I know about, like, all of these things that I know about. And I've never had a job where I could use everything I know. Never.
Yeah.
I would love that. I don't know if it's in the cards.
You do as a podcast host, right?
That's fair. That's fair. Yeah, you're right. Because like today, actually, because I'm driving by and I see this roadside. So I always stop at like these random places. They have this place in West Lynn that they do parts for vehicles that were made before 1965. That's all they do. And I'm like, if I didn't have enough knowledge to talk about cars and mechanics, they would not have agreed to be on my podcast, which is going to happen in February.
Mm-hmm.
But you're absolutely right. Like, I have the ability now to use my knowledge to like communicate with so many people that I never would have possible. And I would argue that the podcast has given me permission to communicate with people. Before this podcast, I would never go up to a random stranger and just introduce myself. Would never do that in a million years. But now I have this podcast like, oh, I host a podcast. Tell me about yourself. Now I have a pathway to have a conversation.
Awesome. Do you want me to keep going through the criteria?
Yeah,
sorry,
please.
I'm like, sorry, I keep sending us. Oh, how many?
No, you're fine.
How many apologies is
that
now? Tally.
At least 10.
Dang it. Okay. Yeah. okay, criteria B, right? So that was the 3 of the criteria A. Criteria B,
Yeah.
subcategory 1. So B, there's 4 subcategories to it, and you only need 2 of the 4.
Okay.
So most of the time, people are meeting all 4 of them. It's like, yeah, technically you only need 2 out of the 4. So subcategory 1 is stereotyped or repetitive motor movements, use of objects or speech. So
So
the example,
stimming?
yeah. So stimming or engaging in echolalia. So like they're repeating the phrases you've heard, right? Again, in Dr. Marsh's assessment material, one of my favorites in that section is sometimes I imitate accents, often without realizing it. And I was like, oh,
All the time.
I'm like, were you on the bus with me? So
I love
that.
it.
Yeah. So that, yeah, reusing phrases repetitively. So that is the palilalia, where like you were quoting yourself. And so you might be repeating a phrase that you said to yourself, like, and I feel like there's like that overlap with like, because sometimes people do that to like, especially in like the ADHD folks of like, I don't want to forget this. So I'm like repeating this. So don't forget to get my keys.
Oh, interesting.
Yeah.
Because I do the wallet keys phone.
Right. Yeah. Yeah.
Every morning, wallet keys phone check.
There's a shower one too. Have you heard about the shower one?
No,
so
tell me.
You don't forget what you've washed. That one's the PTA. So I guess it more applies to female bodies, which are pits, female body that rhymes with it, starting with a T.
Okay.
Probably was allowed to say it, but and then the A is the profanity word for your rear end, for your derriere. So PTA.
Right. Okay.
Yeah. And again, right? Like, because we have, we can have these struggles with hygiene, right? Kind of hearkening back to that other one with the I have good hygiene. How true is it that I have good hygiene? And like, yes, acknowledging many of us have struggles with the executive function demand of taking a shower and the sensory demand of taking a shower, of that transition into from the room temperature to wet and temperature change, and then the transition back out of it with going from wet to dry to warm water to cold air, which kind of ties into this criteria B of like the sensory part that we'll get to in a minute. But yeah, like, see, just an example.
Interesting.
Yeah, so in the repetitive, so the stimming, the language, the echolalia, which is, like is basically seen as a form of like speech stimming, the lining up objects or toys, creating elaborate organizational systems and collections, and then those activities serve to self-soothe. So that's
okay. I get it. Okay.
B1. And then B2 is insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. So this one lists examples: finding security in routines, difficulty with unexpected changes, particularly if they're not self-initiated, and particular rituals such as ways of greeting, morning routines, rituals before exams, and that deviation from those rituals creates significant distress. So I feel like my shower example like overlapped with that too.
That hit home so much.
Yeah.
That hit home so much. So that's B. What's C?
Yeah. No, it's still B. So that was B2.
Okay.
B3 is highly restricted, fixated interests that are abnormal in intensity or focus. So that's the special interest thing. So the example is tendency to learn a lot about an area of high interest, which serves to self-soothe, and the person enjoys talking about this topic and may tend to turn all conversations back to this topic, and it plays a significant part of the person's identity.
And I would be curious about how well I would do on this assessment before and after therapy.
Right.
Because, like, before therapy and before I worked on myself, I could see all of these being a problem. But I have worked so hard to get over all of these things that it's interesting. Like, I get it. Like, I used to have hyper focus on just like watch 22 hours of football every single week.
Mm-hmm.
Now I purposely choose not to because I know if I do, it's a problem. So
Yeah.
how would you encounter or take that into account during the assessment piece?
Right. So, like, my conversation around that is, what's your baseline? What did things look like in childhood? Right. If you
A
didn't have these
lot
tools
worse.
that were learned in therapy, right? Because, I mean, and that's, like, yeah, I guess this is a little bit of a commentary, but that's what ABA was designed to do.
Yeah.
Right. Like, help you act more neurotypical. And yeah, just like, but yeah, the aspect of it anyway, again, soapbox, whole episode in of itself. Yeah. So, and again, right, like, the kind of going back to that thing about non-cis white males, and how we present, and how much more we were pressured and trained into adjusting our behavior so it doesn't look like this, right? Where our tendency, maybe our baseline tendency, if somebody hadn't been like, quit flapping your hands, would have been to flap our hands, for example, right? And so, yeah, so when I am assessing, I'm saying, is that showing up now, or is this, like, again, right, like, getting that lifelong context of, is this only, are you only appearing neurotypical because you've trained yourself to be neurotypical?
Oh, 100%. Oh, yeah.
Right. Yes. I mean, I'm not phrasing it like that, right? I'm not like saying, well, is this actually you, right? But like, but the thing is usually, like, when people are coming for assessment in adulthood, it's because those skills that they've learned to compensate, right, and to cover up their autistic behaviors they are not able to maintain it. They're burning out from doing that, and they are doing more of these things again, and they're like, oh, what is this? So yeah. Anyway, I guess I'm like, what was the point
as I get and it seems like as I get older,
mm-hmm.
it's harder and harder for me to put up those masks and play the game.
Yeah.
It's so much more difficult. And I don't know if that's something that just comes with age, or if that's something that just comes with just life in general, and just saying, you know what, I don't care what people think of me anymore. But I remember it being a huge thing when I was young, a huge thing.
Yeah.
Like,
yeah.
masking was everything.
Yeah. Well, I mean, I feel like definitely for some people, it's like, screw it, I'm not doing this dance for everybody anymore. Right. Like, I'm just going to be myself. And for other people, they're like, I can't maintain it. Yes, it's distressing that people are criticizing me, but I just, like, I don't have the energy for it anymore.
Yeah.
Right. Like, that, and there's, like, the sidetrack of, like, the fact that we also deal with other health concerns that are interrelated to our neurodivergence. But again, that's a whole other topic category.
A whole other conversation. It's one of those things where it's like a complex, nuanced conversation, and it covers so many things that it's like, how do you? Yeah, it's a hard conversation to have.
Yep. So I go back to criteria. Okay, so I'm finally on B4. So criteria B for hyper or hypo. So like more or less than expected reactivity to sensory input or unusual interest in sensory aspects of the environment. And then examples are sensory sensitivities to light, sound, touch, food textures, or taste, or lower response to the sensory input. And then also included in this is interest in visual patterns, craving tactile experiences, so like enjoying the touch of certain sensation of certain surfaces and seeking those out, or like smelling objects, right? Like that, somebody's like, ooh, I'm gonna sniff this. There was this really cute one that one of the people I was assessing shared, which was that because it was like, is there anything unusual that most people wouldn't think of sniffing that you like to smell? And they talked about their cat's tummy, and I was like, oh. And then I smelled my cat's tummy after that, and I was like, oh, this is like soft and. And like I was more.
I may be guilty of that.
Yeah, I was more into like the how soft the fur was, and I was doing like the little, like rubbing my nose on it. I had this one as when I was a kid where I take my hair or my mom's hair and I'd like bundle it up and then like tap it against my skin, like kind of how like if you do a paintbrush against your skin, and so like I liked the sensation of that of like where it, I do it like against my cheek, but I had longer hair at the time too. But yeah, it's kind of hard to do with my shorter hair. I'm like, oh, why don't I do this anymore? Because somebody said it was embarrassing.
I am very sensitive to smells. And actually, it's interesting that you say that because I also want to hate to admit this on the air, but I have a strong affinity for how cats smell.
Mm-hmm.
I love the smell of cats. And so like I will sneak a sniff of every cat I come across if I can, unless I try not to get caught because people think it's kind of weird.
Yeah.
But I just have an affinity for how cats smell.
Well, I don't think it's weird, but I'm not allistic, right? I'm in the autism group too. I will smell those cats too, right? Like I was like, ooh, the belly. How's the belly smell? I'm like, right? Because I think that person was like, I don't know, this might seem kind of weird, but I smell my cat's belly, and I was like, ooh, no, I'm totally gonna smell my cat's belly now. I don't think it's weird.
I'm gonna totally do that too. I don't smell her belly. I've never done that, but I'm keeping my eye on Willow right now. She's got a weird look. Like, what you looking at me for?
Your belly. It's like reverse. What's his face from Austin Powers, where he's like, "Get in my belly."
Yeah.
I'm gonna get in your belly.
Oh, I love it. I love it. Oh, that's great.
Okay, so I got through criteria B. That one you just need 2 of the 4 categories. And then criteria C. So that one is basically like, I'll just read the thing. I was like, do I describe it? So the traits must be present in early developmental period. So had to be present in childhood. It might not, they may not have become fully, she uses the word fully manifest, so fully obvious, fully apparent, until the social demands exceeded limited capacities, or might be masked by learned strategies later in life, right? So that's like was a part of our conversation earlier of like, well, what if, the person had all these compensatory mechanisms and now they're getting to this point of burning out and like essentially got forced to unmask. And then criteria D is that the traits cause clinically significant impairment in social, occupational, or other important areas of current functioning. And criteria E is these disturbances are not better explained by intellectual disability or global developmental delay. I think also, so that's on hers, but like my understanding also is or by another condition. Right.
Okay.
And so that's one of those things where if you don't have a neuroaffirming assessor, there, like, like when I shared my experience, that there can be that where that is criteria E is where that particular clinician might exclude the diagnosis for somebody, saying, oh, well, you have trauma, and so all these symptoms are due to trauma. And you're like, these symptoms have been present since I was like 6 years old or 4 years old. Like, so
Yeah.
you're saying I was born with trauma, right? Like, and I mean, and sometimes, yeah, that's the case, is like we're born into a household that has a lot of issues. And oftentimes in that situation, it's intergenerational. And so, you're growing
Yeah.
up in a household like that. Your parents grew up in a household like that. Your grandparents grew up in a household like that. And so, like, but is that to say like that nobody with complex trauma could be diagnosed autistic? And I mean, depending on,
Yeah.
like, I mean, certain scientists have the perspective that autism and ADHD and like those are the main neurodevelopmental conditions that get mentioned, but that so there's there are clinicians and scientists that regard neurodivergence as a manifestation, as a response to trauma, as a manifestation from trauma. So like Gabor Mate is one of the ones that's like ADHD is caused by trauma. And so, which is like, I have mixed feelings about that
That's
perspective.
that's an
Yes,
oversimplification if I
yes,
ever heard
exactly.
one. Like that's wow.
And
That's
right. So
almost as bad as that's
no, go
almost as
ahead.
bad as that diagnostician in Southern Oregon who doesn't believe that you can have ADHD and autism in the same person.
Well, up until 2013, when the DSM-5 came out, they were, if you were
Yeah.
diagnosed with one, you were automatically excluded from being able to be diagnosed with the other. So I'm wondering if that
Wow.
clinician is still DSM-4 and before.
That's frightening if they are.
Right? Right. Yeah.
Huh.
Like if you're still assessing, like keep up. Yeah. But I mean, I like otherwise, yeah, I'm like, how I will acknowledge, and I mean, I see this show up in myself all the time, is
Yeah.
that sometimes symptoms, traits, characteristics of one will mask traits of the other, right? So like my impulsivity from my ADHD oftentimes covers up my social anxiety piece under my criteria A of autism, right? Where it's like, where's that part of like developing different, like, uh, of the, and the social
Yeah.
interactions and stuff, right? Where like my impulsivity is just like, say, like I keep joking about like, oh, sorry, no filter.
Right.
Where so like I end up presenting way more extroverted than people expect an autistic person to be, but what they
Oh,
don't
I
end
know
up
what you
seeing,
mean.
sorry, oh 11 11 apologies, right? uh what they don't end up seeing is me crashing after that because of the demand of that social interaction, right? They see the interaction and like, um and they're like, how could you be autistic? Like you talk a lot. You're a doctor, right? Like that, but it's
Yeah, it's like my primary care doctor. When I told him I was autistic, he looked at me and didn't ask any questions, didn't say anything or inquire other than to say, "Oh, you must be really high functioning," and that was as much as he was willing to talk about it. I'm like,
yeah,
until I'm not, but that's okay.
yeah, yeah. I know. Well, and that's the other thing too, is like when we deliver diagnoses, right? We have to make a judgment call based on the assessment, right? Like that, those number of visits. Oh yeah, so I guess I should speak to that a little bit. Which I'll circle back around to, but of their support needs at that moment, right? And I personally don't believe that that is static, right? So somebody might be assessed as level 1 when they present for their assessment.
Yeah.
But 6 months later, maybe stuff happened that exceeded their tolerance, right? That has then shifted them into level 2, needing even more significant support, right? Than what they needed at that time. But if it was just like, if the I mean, I'm grateful that,
and that's a good segue into the cycle that I've sort of seen.
Mm-hmm.
So like there is a cycle. Oh, I lost you.
Uh-oh. It says reconnecting. Am I back? Am I back?
All right, we're back.
Okay.
We're back. What were you saying? Sorry.
Oh, no, I think you were saying something. The cycle.
No, I apologize.
The cycle.
Oh yeah, so there's this cycle, right? So like what I've noticed is, and I can take this out of my own life, right? Where you get to that burnout stage and you go from like a level 1 to a level 2, and you need those additional supports, but then those supports aren't there, and that leads to a mental health crisis.
Mm-hmm.
And the longer you go without treating those needs from that shift from level 1 to level 2, the higher likelihood that depression and suicidal ideation
Mm-hmm.
and all of those other things come into play, because you don't understand, like you were diagnosed as level 1. I don't need all these supports. What is going on? I'm confused. I feel alone. And then you don't go back to your doctor because you're like, I'm only supposed to be at a level 1. And then there's that cycle. And it's a scary cycle that I've experienced once in my life. And I appreciate the extra context between the different levels and at different points in your life, because I don't think people fully appreciate or understand that at any point a life event is going to shift that level.
Yeah. And I honestly, like, I feel like I keep, I don't want it to sound like I'm complaining about it, but like, I feel like there are too many clinicians out there still that view it as something static. Like, no, you should be able to pull this together. You're a level 1, right? And it's like, level 1 still has support needs, and that support wasn't provided. So now I need even more support. Don't you tell me. Yeah. Well, and that depression thing, I know I shared some of it last time, but like I had, where it was like kind of flipped, where like I was getting treated for depression and anxiety, and then later complex trauma, but all the usual gold standard treatments were like a drop in the bucket as far as them addressing what I was having a distress about, because it wasn't fully supporting the neurodivergent aspect, right? It was like, oh, take this SSRI because it's a chemical issue, right? Or like do these things because that, like change these aspects or whatever, exercise more, do some yoga, right? Like, again, like addressing like the nervous system aspect to it, while yes is involved, but it's still not fully addressing what my support needs are, when it's just, and for so long, right, not seeing it myself through the neurodivergent lens, I was like, why aren't these treatments working for me? What's wrong with me?
Yes.
And so that's
Yes.
why I got so
And
obsessive, as it were, about pursuing a diagnosis.
my primary care doctor was getting frustrated with me because those interventions weren't helping and he didn't understand why.
Mm-hmm,
And
mm-hmm.
that was way before I even heard the term autism. Like for the longest time, my doctors, like all of these medical problems and things that I perceived as just like being sick. Well, now that I know I'm autistic, like, no, I'm not sick. I just have sensory issues.
Yeah.
And for the longest time, I just thought I was actually sick.
Yeah. Yeah. It's like,
Yeah. It's all making sense now. I really appreciate that we had this conversation because, like, this is the gap. Because, like, I didn't go through that formal autism diagnosis.
mm-hmm.
I had no idea.
Yeah. So, I mean, I guess in summary, right, like, different clinicians will use different tools. They'll often, like I said, it'll be like like either that ADOS, and like I said, that's the one that typically is the main one that gets used to assess in childhood, and or like that ADIR, or like the one I use, that MIGDAS one, and yeah. So I guess the other mention I was going to make is that in my private practice, I also do a series of like screeners, so that this ties back into like, you know, what 3-hour visit, do you have 2 visits, do you have 3 visits, how does that all work? And it just depends on how many tools that the clinician is using to assess, and how long each of those tools takes to deliver, um,
Okay.
and you know, which can vary, right? So like I say, so like with the autism assessment, adult autism assessment and services, our assessment is broken up into the 3 sessions. And so we do screener 1 in that first session, and we do that SRS 2 in that first session.
Okay.
And then, well, I get technically the first half hour of that first session, because it's an hour and a half slot, is like a kind of a, what would they call it, meet and greet intake thing, which is basically like,
Okay.
do you want to do a full assessment? Do you even need a full assessment? Like, how likely are you autistic, right? So that's where we do like that screener aspect. But you know, so that somebody's like, oh, wait, it is all out of pocket. Oh, shoot, I can't actually afford it. Right. And so then they're not on the hook for like having to pay for all it. Right. But if they're like, yes, I want to move forward, then we're like, yes, we can start today. Do you want to start today? And so then we do that screener, and then we do the SRS 2. And then the second session, we do part A and part B of the proprietary tools. And then session 3, we do C, D, and E. And then she also has a proprietary masking questionnaire that's like 20 questions long. So that it's like, and here's why the person has fallen through the cracks this long. And at that time, we're delivering the diagnosis if they have met the criteria. And I usually, like, when I'm presenting the diagnosis, I like, you know, I tend to do it in like a celebratory fashion of like, dun da da da, congratulations, you're autistic, welcome to the
I
club.
love that. I love that.
Yeah, so again, right, like like my goofy thing. But yeah, and then so in my private practice, it's a little bit different because I use a little bit different set of tools. And so I have folks do, I was going to pull up my little checklist so I could like just like say, here's what I have them do. So I have them do a set of screener questionnaires that are on the Embrace Autism website, so that you can just do, because that has like this auto scoring, and then the person can just download a PDF of their results. And so the screeners that I have them do the RADS-R. Are you familiar with that one? Okay.
Yep.
And that's what like a lot of people who are doing like self-assessment, right, or self-diagnosis,
Yep.
will do the RADS-R. Like,
They'll do the RADSAR or
So rads are,
the AQ.
yeah, yeah. So I use the rads are the RBQ2A. So that's the adult. So rads are was RITVO Autism Asperger Diagnostic Scale revised. That was 80 questions long. So it is,
Okay.
a little bit involved. RBQ2A is Adult Repetitive Behaviors Questionnaire. And that one's 20 questions. I use the CAT-Q, which is the Camouflaging Autistic Traits Questionnaire. So that's getting into the masking. That's 25 questions. So these are all self-administered. So they just go the Embrace Autism
So
website.
you send them out beforehand and have them.
Yeah, yeah.
So do you have them? Okay.
And actually, yeah, I think now that I think of it, I'm like, I think I may have like integrated some of them into my EHR so that they don't have to go separately to the website. But yeah, at first I was like, go here to do this. And then I used the Toronto Empathy Questionnaire to get that piece of like how are you showing up in the social relationships. That one's 20 questions. And so I have them do those as part of like their intake paperwork with me. Or like if it's a patient that's already established with me for something else, like, oh, maybe somebody's already seeing me for their thyroid issues or mental health stuff. And they're like, hey, I want to get it assessed for autism. And I'm like, yeah, sure. Here, start with these. And so, yeah, so that gets done ahead of that first assessment appointment. And then I do kind of like a screening appointment, as it were. So this is more applying to the patients that aren't already established in my private practice.
Yeah.
So I'll have that initial appointment. It's like, tell me why you're looking at assessment this time. Tell me more about your background. Here's what your questionnaires are saying. And then from there, I'm sending them that SRS2, which they can complete on their own. And like any of these, like if they'd rather me verbally deliver, like I will do that, but that ends up taking more appointments, right? Because we're actually spending appointment time to do all that. But if they're fine doing the self-administered ones, I will do most of that outside the appointment. And then, so there's that initial appointment of like, why are you here? Or like, tell me the details about this.
Right.
Which is usually where, all this stuff happened in my childhood. Here's how stuff has showed up as an adult. 2 of my kids have gotten diagnosed, right? Like the family history part comes out. And so then I send that, like I said, I send them that SRS2 after that appointment. And then the following appointment, I start doing that MIGDAS interview. And oftentimes we can get through, it depends on how tangential people can get, right? So, and I am not like, yes, I like, some clinicians might be like, okay, back on track. Let's get, but I'm more flexible because I don't want to have the whole thing cause distress, right? Or cause undue distress. Yeah. So like part of my neuroaffirming approach is, like if you need a little bit more time to think about your answers to these questions, because that MIGDAS interview is more open-ended, right? And so, people might be like extremely detailed about how they're answering some of those. And so I make sure I create space for that. But yeah, on average, we're usually able to get through that in 2 visits, because I do 1 hour visits for those because they're follow-up appointments. And the MIGDAS, like the average completion time is like about an hour and a half. And again, right, like I'm like, if we're making space. And so we're usually able to get to it over the course of 2 visits. Sometimes, again, if people have longer processing time needs and stuff like that, it can extend over more visits than that. But usually mine is like 3 visits total. two of which are an hour piece. And the first one, like, again, if they're a new patient, the first visit, my first new patient visit is an hour and a half long. But if it's like a returning patient, then that one's a
Okay.
hour as well. So that's how it works for me in my private practice. And then like on the insurance side of things, because I'm more under like that primary care umbrella, I'm billing as an office visit, not the psychological assessment billing codes that, like, if somebody was
Okay.
going to a psychologist, that's how it would get billed under. But I'm integrating it into
Gotcha.
my medical visit, right? And so like how just like when we're like, if I'm working with somebody like with depression and anxiety, where like I'm using, these standardized tools that are like assessing their symptom presentation, that's what I'm doing. And it's just, yeah. So it's slightly different because of like the provider type that I am. And, but
Okay.
yeah, so like in the psychologist setting, I feel like, like I don't know if it's uniform no matter what psychologist you go see. My impression is that it's not, because, like me sharing my story about the first psychologist that I saw for my first assessment, versus other people's stories about psychologists that they went and saw. Oh, looks like I'm reconnecting in. That it sounded different and how the things were set up. So, but I will say, like, when my kids were assessed, how that was set up, I think we had a screening appointment where us as the parents met with the psychologist and gave like the background information of like why we're seeking out assessment. And then they had two or 3 hour sessions with our kids, because we had separate ones having separate assessments. My internet, or yours, is not happy. And then we had a debrief appointment.
It happens.
Yeah. And then we had a debrief appointment after the two main sessions. But with my kids' assessments, not only were they doing the ADOS, but they did like IQ testing and like some extra tools in there too. So again, it's like it varies of like what they're looking into. And I think I know, at least with our younger son, because we were mainly assessing for ADHD, but we did want him assessed for autism as well because of family history. And so like his report, they were like, yes, definitely meet the criteria for ADHD. They're like, it's too soon to tell if the autistic traits that he has are due to the ADHD or if they're due standalone to the autism. And so we're not excluding it at this time, but we want to see if the ADHD is better supported. Are these characteristics still around, or are they managed with the ADHD interventions? And I was like, okay, that makes sense. And so, we'll
very pragmatic.
That.
And we're back. Had a little bit of a technical glitch. We'll figure that out. So thank you very much for hopping back on and finishing our conversation.
Yeah, of course.
And you were just talking about how your doctor that you had your assessments for your son, right?
Mm-hmm.
Yeah, it was very affirming in that response. I really appreciate that. I like to pay attention and to see what happens and do what's in the best interest of the child. I think that's awesome.
Yeah. It was a very it was an awesome experience. And actually it was the same clinic that we went to for my older son's assessment back in 2020. And should I plug them? Identify them?
Sure.
So they only assess under 18. So we're
okay.
So they don't do adult assessments. So that is Mind Sites. And so they have locations in Portland, and we did the ours through the Bend office because we're over in Central Oregon. And yeah, so we had a really good experience with both of our sons' assessments. So yeah, and it turned out that my older son's assessor, his psychologist, she had been in graduate school in her psychology program at the same time that I was in med school. And we actually had a collaborative mental health clinic with her school's program, and we weren't in that clinic at the same time, but we both did rotations through that clinic, so that was really cool to find out. She's like, I feel like, she's like, I recognize your school name, and yeah, it was really like, so we geeked out about that. But yeah,
It
so
is
that was
such a small world.
yeah. So I was like, this is a good sign. Which then makes me think of those shirts that have a picture of a sign saying "good" on the sign,
Right?
and that like pleases
I
my
love it.
literal brain. Good, it's a good sign. Yeah, yeah, yeah. So
So we've been at this
yeah, I was just gonna say, did that answer your questions about assessment?
100%. And we've been at this for 2 hours.
Yeah, yeah.
So thank you so much.
You're welcome.
I can't express, like, every time we have these conversations, my eyes are open to another aspect of my own autistic pathway. So I really appreciate you taking the time today and having these conversations, because a lot of people, I imagine, have these questions but have no way to find this information. So I really appreciate you being candid and sort of openly talk about that. And if we were in person, I would be giving you a kindness coin right now. So I'll give you one virtually. But I
Yeah,
just
no,
wanted to
I
say
don't
that.
mind.
And
I do not mind having conversations about this and them lasting hours. And right, like I feel like the underlying theme also is special interest, right? But this, like, I mean, this is part of my special interest, right? So I'm like, yeah, let me
yeah,
talk about it. And here's all these details, right?
same.
So yeah, so I
And I'm
appreciate it too.
always trying. Sorry, I was just going to say, I'm always trying to have better ideas of what I can say to help explain things. So I really appreciate the information.
You're very welcome. Yeah. And I will talk, yeah, I will talk about whatever, whether it's related to related to like actual clinical practice or not, right? Like if you want to have a random
Yep.
conversation about some random interest that we happen to share, like yeah, I don't have to be in doctor mode, but
You
I don't know.
got it.
I mean, I will oftentimes find some connection between something and like science and medicine. So even if something seems like way opposite of like, well, actually, did you know
Right.
this also and how the brain blah, blah, blah. Yeah, like I feel like I'm obsessed with the brain.
Well, Dr. Jami, thank you so much. I really appreciate it. We will do this again.